as a PHC, primary healthcare center medical officer, you see a 25-year-old man who has come with painful lesions as shown below. On examination, he has multiple deep ulcers over the shaft of the penis which are non-indurated with soft ragged margins and unilateral tender lymphadenopathy. Unilateral tender LNP is lymphadenopathy. And there is no history of any fever or allergy with usage of any medication. So what is the kit which is to be used? And yes, if you have marked the answer as option B, that is kit 3, which is white kit, you are absolutely correct. So before that, you should come to a diagnosis about what is this condition. Okay, so STD, sexually transmitted diseases, are a very important topic for exam point of view. Not just AIIMS, even NEET and also FMGE. So I will try to just summarize the sexually transmitted disease in this short, brief summary. So if you see, the clues which are given are that the lesion is painful and there are multiple deep ulcers. As you can note here in the image also, there are multiple deep ulcers which are non-indurated and soft. So with all these clues, if you have diagnosed that yes, this patient has a CHANCROID, then yes, your diagnosis is absolutely correct. So let us quickly go through the CHANCROID and the most important differential diagnosis, which is syphilis. So CHANCROID, it is also called as soft chancre. So that is the another name for this condition. You should all know this. And the causative agents, incubation period, these are the most important thing along with the clinical features. So the causative agent is Haemophilus ducreyi. Please remember, in the exam they can simply give you what is the causative agent of this condition. That also can be a question. Yes, it is Haemophilus ducreyi. And incubation period is 3 to 10 days. So apart from this, clinical features are very important. As you can see here again in this picture, you can notice that there are multiple ulcers. The patient is going to have extreme pain, and also if we try to palpate, there is also going to be a tenderness. And yes, these ulcers, if you try to palpate, they are going to be very soft and they are going to easily bleed on touch. These are bleeding ulcers, and yes, the base is going to be necrotic base. So if you consider these are the 5 features of chancroidal ulcer, then you will you yourself understand the exact opposite are the features of syphilitic ulcer. Syphilitic ulcer, which is basically caused by Treponema pallidum. Yes, so in the chancroid we have seen that there are multiple ulcers which are going to be extremely painful, which are very soft in consistency, which are going to very easily bleed on touch, and they are having a necrotic base. So the exact opposite of all these are, yes, in syphilis we are going to see single ulcer. There will be a single ulcer, and this single ulcer is also going to be painless, and there will be a button-like indulation, and no bleeding. There will not be any bleed on touch, and the base of the ulcers is going to be very clean. So this is the contrast between syphilis and chancroidal ulcers. I hope it is very clear. If it is clear, please do hit that like button. And if you look at this is the NACO kit for syndromic management of the sexually transmitted disease. As you can see here, the kit 1 is going to be used for urethral discharge, cervical discharge and painful scrotal swelling. Kit 2 is used for vaginal discharge. Kit 3 and 4 both are used for non-herpetic genital ulcers, and kit 5 is used for genital ulcer, which is herpetic in nature, and 6 is for lower abdominal pain, and 7 is inguinal bubo. So just to summarize this in a very easy mnemonic, so I hope all of you know who this personality is. By remembering this personality, we can remember all the kids. Grey, green. So yes, grey girl wearing bracelet and reading yellow book. Yellow book. Okay, so this is the mnemonic: grey girl wearing bracelet, reading yellow book. So all the kids are going to be memorized in the particular order in easy to remember fashion. So grey is grey kit. This G stands for green, so the second kit is green color, which is used for vaginal discharge. And W wearing white, this is white kit. And B for, I hope you all remember the bracelet color of this bhai, so it is blue. So kit 4 is blue in color, kit 3 is white in color. Yes, I will write it here for your convenience, green color. This reading is red color, yellow is yellow, B here is black. Okay, so these are all the kits in the order you can remember: grey girl wearing bracelet, reading yellow book. And I will try to just summarize all the sexually transmitted diseases and their manifestation. So you can see ulcers. If there are multiple painful ulcers, we should check the lymph nodes. And the only two possibilities of the multiple painful ulcers which are there over the genitalia are either it could be chancroid or it could be herpes. So these are the only two possibilities. So if we examine the lymph nodes, and if in the lymph nodes we find that unilateral lymphadenopathy is present along with suppuration, that is pus collection, then the diagnosis will be chancroid. And if there are bilaterally enlarged lymph nodes but without any suppuration, then the diagnosis is going to be herpetic ulcers, genital ulcers. And now coming to this side, single painless ulcer, if it is present, then if we examine the lymph nodes, and if the lymph nodes are not enlarged, then the diagnosis is going to be donovanosus. And if the lymph nodes are bilaterally enlarged but along with the ulcer, if the lymph nodes are also painless, then the diagnosis will be syphilis. And if the lymphadenopathy is present and if they are painful, and if there is again suppuration, that is, it is called bubo. So bubo is not only seen in chancroid, bubos are also seen in LGV, lymphogranuloma venereum. So one question for all of you: what is the causative organism for LGV? Please type your answer in the comment section below. Yes, so grey girl wearing bracelet, reading yellow book. So you can take a snapshot of this and you can revise that. And not only that, for any type of your doubts in dermatology, just type DrMSD followed by whatever doubt you are having in the YouTube search option. Most likely you are going to get the answer in the form of a video. Okay. So here in the question, the options were given as kit 6 yellow. I hope you all now remember that it is for lower abdominal pain. And yes, kit 3 is white color. It is for non-herpetic genital ulcer diseases. Okay, so that is the answer here. And if in case in the question it was mentioned that the patient is having allergy to penicillin, it was mentioned that the patient is having allergy to penicillin, then we should not use kit 3, then we have to use kit number 4, which is blue in color. So blue kit is going to be used in those cases in which penicillin will not be present. And kit 1, yes, kit 1, it is going to be used for urethral discharge, cervical discharge, or painful scrotal swelling. Kit 2, green color, is used for vaginal discharge. So this is a brief summary of whatever important STDs are can be asked in the MCQs. So this is a very, very important repeat MCQ. So International Contact Dermatitis Research Group advises first and second patch test reading to be taken in allergic contact dermatitis diagnosis at so and so hours. So what are these hours? So first of all, you should know what are this contact dermatitis. So contact dermatitis are of two types: irritant contact dermatitis and allergic contact dermatitis. So we'll not go into the details of this, but yes, allergic contact dermatitis, the mechanism is, it is dependent upon immunological mechanisms, and you must remember that it is type 4 hypersensitivity reaction. It is due to type 4 hypersensitivity reaction. And one example for ACD is airborne contact dermatitis, and there are various substances which can act as allergens, and in the metals it is nickel, and in the antibiotics you can remember neomycin, and in the cement it is potassium dichromate. I hope it is not obstructing. Okay, I am obstructing, so I will move on to the other side. So yes, potassium dichromate. Okay, so now let us see. Yes, as you can see here, nickel, neomycin, potassium dichromate, and of course in bindi it is paratertiary butylphenol. These are all the possible allergens. And in the hair dyes we have paraphenylene diamine. So yes, this patch test, it is basically works on the principle of identifying the identifying the type 4 hypersensitivity reaction. So there could be a possible question on this also, we'll see that. So yes, how is this patch test performed is, we will take some fin chambers which are made up of aluminum, and we are going to fill those chambers with the allergens which will be available commercially as pre-filled syringes, and we are going to fill these small aluminum chambers with whatever possible allergens we think that the patient is having allergy to. So like for example nickel, we can fill this with PPD, we can fill this with potassium dichromate, we can fill this with paratertiary butylphenol, which is which is the allergen in bindi, so on and so forth. So like this we'll fill this, and yes, these are the pre-filled syringes which will be available in the market for direct application by us dermatologists. We will apply this over the back of these patients, and we'll call these patients after 2 days, and after 4 days. And you must remember that yes, though there are two readings which are taken, one at 48 hours, that is 2 days, and the other one at 4 days, that is 96 hours, there is a possibility that few patients might get a delayed reaction. That is the reason why the best reading can be taken at 96 hours, that is on the 4th day. So after the removal of these allergens, you can notice that the patients might not have any type of response over those areas which the patient is not allergic to, whereas you can see there is some development of erythema, and also there is some development of vesicles or other areas whichever the patient is having allergic response towards. So this is graded like plus, 2 plus and 3 plus. If there is erythema, it is called plus. If there is formation of vesicles along with the erythema, we call it as plus, double plus. And if there are not just vesicles but there is a confluence of these vesicles, we call it as triple plus. So triple plus simply means extreme positive reaction. The patient is extremely allergic to that substance, so we should ask the patient to avoid that substance or coming into contact with that substance. Now this was not a previous year question, but yes, all of the following correct statement among the following except. So investigation of choice in allergic contact dermatitis, we have seen this already. Yes, patch testing is in fact the investigation of choice, and this documents type 4 hypersensitivity reaction. Yes, this is also right, and this documents delayed type of hypersensitivity reaction. This statement is also right. So all of the above is the answer in this question. And the same question when I asked in my Telegram group, that is Crack Derma with DrMSD, you can see that students suddenly answered option A without even noticing, some of them without even noticing option number 4. I hope definitely you all know that yes, it documents type 4 hypersensitivity reaction. It is going to document delayed type of hypersensitivity reaction, which is the other name for type 4 hypersensitivity reaction. So what is that carry home message is, whenever you get a question in the exam, anything INICET, NEET or FMGE, be very cautious, read all the options carefully, and then only go to the next question. Okay, please don't be in a hurry. This is one suggestion which I want to give all of you. So if you want to join my Telegram group, the links are there in the description below. You can join with the help of that link. So melasma, chikungunya, fixed drug eruption, this is a very important differential. We shall see this question in the next question, because this was asked repeatedly in various years in the AIIMS. So let us discuss this topic chikungunya in the upcoming videos. So in the comment section, just type hashtag DrMSD if you want me to make this kind of videos further. Yes, a 5-year-old boy. This is the next question. A 5-year-old boy has painful sores in the mouth with a rash over the hands, and there is also fever. So you can see hands are involved, mouth is involved, and in the picture even feet is having some lesions. So with all these clues, if you have diagnosed this disease as hand foot mouth disease, you are absolutely right. Yes, it is indeed hand foot mouth disease. Okay, but the examiner is asking what is a causative agent, and if you have marked Coxsackie virus, yes, you are absolutely right. So now let us briefly revise what are the viruses, what are the conditions which are associated with, and what are the manifestations. So pox virus, a very important disease which you must remember caused by pox virus, is molluscum contagiosum, which is basically going to present with skin color to pearly white papules which are going to have central umbilication. And if you do a histopathology, we can see molluscum bodies, which are nothing but HP bodies. So if you know the full form of HP bodies, please type your answer in the comment section. I will check out the answer. So yes, Coxsackie virus is associated with hand, foot, mouth. It is basically a type of enterovirus. So we'll see that in the next slides. So human herpes virus 7. It is associated with some important skin manifestations, one of which is pityriasis rosea. This is associated, and also it is associated with exanthem subitum. And I hope all of you know parvovirus, the slapped cheek appearance, parvovirus B19 is associated with erythema infectiosum, which is going to clinically manifest with a child coming with slapped cheek appearance. We might think that there is some trauma to the child caused due to the parents or guardians, but it is not so. It is due to this virus, parvovirus B19, erythema infectiosum. And coming to the question in the MCQ, if you remember, we have seen that the child was having involvement of the palms and soles. So this palms and soles involvement is very, very limited in dermatology, and you can remember what are the conditions which can manifest with lesions over the palms and soles. So we call them as centrifugal rashes. That is the rash if it involves the palm acral parts, more distal parts, they are called as centrifugal rashes. And in these conditions, palms and soles will be involved. Very, very few conditions, like for example, you can remember the mnemonic CARS. Just remember, steering of the car is handled by the hands. So CA stands for Coxsackie A virus. Yes, that is hand, foot, mouth disease. And R stands for Rocky Mountain Spotted Fever. And S stands for secondary syphilis. And my question to all of you, what is the vector in Rocky Mountain Spotted Fever? So if you know the answer for this question, type your answer in the comment section below. So these are all, I hope this is, don't need any introduction to this. Microbiology, you might have read this in very particular detail. So yes, enteroviral infections, hand, foot, mouth disease, it is caused by Coxsackie A16 and enterovirus 71. So these strains are also very, very important, A16 and enterovirus 71. So what will be the clinical features in hand, foot, mouth disease? As the name of the disease suggests, there will be manifestation in the hand and feet, and also mouth will be involved. In the mouth, we are going to see oral ananthem. Over the hard palate, you are able to see some erosions and ulcers are present. Along with that, yes, the exanthem is going to be in the form of papulovesicular lesions which will be present over the palms and soles, and also buttocks can also be involved. And so you can see here, these are the papulovesicles which can be seen over the palms and soles, and it is basically a self-limiting condition. It is a self-resolving condition. This is the next question. Topical steroids are most effective in, and if you look at the options, you can easily at least rule out them if you do not know or if you are not sure about the answer. So dermal atrophy, basically the steroids, topical steroids, if they are used for a prolonged period of time, they are going to reduce the fibroblast numbers, because of which there is going to be a development of dermal atrophy. So option A is definitely not a condition where we use topical steroids. And option C and D, if you look, they are both viral infections. So herpes simplex virus and herpes zoster, which is caused by varicella zoster virus. So both of these are viral infections, and I hope you all know that in viral infections we should not use, and in fact steroids are contraindicated in viral infections, because if we use the steroids which can produce compromised state, then there can be even more proliferation of this viral particle, so we should not use. So we are left out with option B, which is the answer here, eczematous dermatitis. Yes, topical steroids are most effective in eczematous dermatitis, and in the acute phase of the eczematous dermatitis, the patients are going to have oozy lesions. There will be oozy lesions, and this oozing is basically because of the presence of the spongiosis. Spongiosis will be present in particular which part of the epidermis? Yes, it is stratum spinosum. In the stratum spinosum, there is going to be a collection of the fluid, because of which there is going to be a spongiosis, which will clinically manifest with oozing. Okay. Yes, so this we have already seen, and in the treatment also, this was the previous JIPMER question. You must remember that in the acute phase of this, eczema, the patient, we have to advise the patient to use wet compresses, and we have to advise the patient to use cream based formulation. Why? Because the ooziness, any other type of formulation will not stay over the eczematous lesion. So cream is the preferred option in acute eczematous phase, whereas in the chronic phase of the eczema, whereby the lesion becomes lichenified, that is, there will be thickening of the skin, increased skin markings will be there, and hyperpigmentation will be there. In such case, we should not use a cream based formulation. Instead, we have to use ointment based formulation. Okay, because it will stay at the site wherever we are applying, and this will also provide the occlusion which is needed for the proper absorption of the steroid chemical which we are keeping in that vehicle, ointment based vehicle. And this is the next question: which cell is uh, not present in the layer pointed in the image? Which cell is not present in the layer which it is pointed here? And you can see here, so this is the arrow which is pointing towards this part, and if you have identified, this is the cut section of a skin which you are looking under microscope. And how can you know that? Because you are able to see these differentiation of superficial epidermis and the deeper dermis. So that is the first thing. And there are some projections of the epidermis into the dermis, which are called as rete ridges. Rete ridges are the projections of epidermis into the dermis, whereas you are also able to see there are some projections of the dermis into the epidermis, and these are called as dermal papillae. These are called as dermal papillae, and the arrow is pointing towards a dermal papilla, but most importantly you should understand that it is pointing towards a place where there is a junction between epidermis superficially and dermis in the deeper part. So this is basically the stratum basale which the examiner is trying to point out. So first thing which you should be in a position to do is identifying that the arrow is pointing towards stratum basale. And now comes the next thing, which is the cell which is not present in this layer. And yes, if you have marked Langerhans cell as the answer, you are absolutely right. So let us see these cells which are there in the epidermis, and what are those important features which you must remember about each of the cell. So there are 4 cells which are present in the epidermis. The first one are the keratinocytes, which are basically the local cells forming up to 90% of the bulk of the epidermal cells. And the next one are melanocytes, Merkel cells and Langerhans cells. So if you observe carefully, there is one thing common between melanocytes and Merkel cells. And what is that common thing? Both these are present in the stratum basale. So that is the one thing in common. And Langerhans cells, these are dendritic cells which are present in more numbers in stratum spinosum. And keratinocytes, they are omnipresent in all the layers of the epidermis. Keratinocytes are present. Okay. And next thing which the examiner might ask you is, what is the embryological derivation of these individual cells? So yes, keratinocytes are derived from ectoderm, and melanocytes are derived from neural crest. Merkel cells are derived from ectoderm more than neural crest, and finally Langerhans cell, they are derived from bone marrow, that is mesoderm component of the bone marrow. So these are some of the important points about the cells of the epidermis, and there is one very important and easy to remember way to remember all these layers from top to bottom. So the mnemonic here is, come let's get sunburned. So from superficial to the deep, it is stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basal. Then there is one peculiarity of stratum lucidum. This layer is only and only present in palms and soles. Otherwise there are only 4 layers in the rest of the body parts: stratum corneum, granulosum, spinosum, and stratum basal. Okay, I hope you all can remember with this mnemonic. So basically, come let's get sunburned. What is sunburn? You should know. Sunburn is actually a music fest which happens every year in Goa. So I hope all of you are going to Goa after the results are announced, after you have joined your PG, and I hope you all will also call me to the party to join all of you. So if you want to call me, just give a thumbs up to this, like to this video. Okay. So yeah, Langerhans cells, few important point about these Langerhans cells. As you can see here in the epidermis, we can see in the stratum spinosum, there is this dendritic cell which is present. These are basically antigen presenting cells. And on electron microscopy, if we observe under electron microscopy, we can notice one very important structure in the Langerhans cells. So if you know the answer for whatever I am asking, please type your answer in the comment section. But yes, I will show what are those. They are called as tennis racket shaped Birbeck granules. Tennis racket shaped Birbeck granules can be seen on electron microscopy. So to identify the Langerhans cells, the investigation of choice is electron microscopy. Okay. And yes, we have seen this already. Merkel cells are embryologically derived from. So there was some confusion for this. So, but there has been a clarification that yes, it is ectoderm which is a better answer over neural crest. So ectoderm would be a better choice to mark. Okay. So that's it in this video, friends. So I hope all of you enjoyed this video. Please do hit that like button if this